Welcome to the Community-Based Strategies to Improve Health and Well-Being session. My name is Amy Bellman-Davis, and I will be moderating this session today. Our speakers include Shannon Findlay, Karina Weinstein, Jack Long, and Lindsey Pollaczek. I am pleased to introduce our first speaker, Shannon Findlay. Shannon Findlay is a clinical assistant professor of emergency medicine at the University of Iowa. She has earned the Certificate of Knowledge of Clinical Tropical Medicine and Traveler's Health. Her interests also include human trafficking awareness and the development of social medicine. Please join me in welcoming Shannon.
Hello, everyone. Thank you for having me today. Today, I wanted to talk to you about Helping Babies Breathe, a modified approach. Helping Babies Breathe is a neonatal resuscitation program. One of its goals is to reduce neonatal mortality. Global neonatal mortality has been a core target of both the Millennial Development Goals and the Sustainability Development Goals by the United Nations. In 2000, global neonatal mortality was 31 per 1,000. We did see a decrease to about 17 in 2017. Despite this decrease, we can see that there are large disparities in global neonatal mortality. Japan has less than 1 per 1,000, while we see Afghanistan has 37 per 1,000. Low to middle income countries seem to be most affected by disparities found in global neonatal mortality. One reason is thought to be access to quality care. This is due to prior to birth, at the time of birth, and then within the first month of life. We also have found that women receiving care by midwives who meet regulated international standards do have healthier neonates. They're about 16% less likely to have their baby die and about 24% less likely to have preterm births. The most common conditions that affect neonatal mortality include preterm birth, birth asphyxia, infections, and birth defects. Helping Babies Breathe focuses on birth asphyxia. The WHO, the World Health Organization, estimates about 1 million neonates die from birth asphyxia each year. In resource-limited countries, about 30% are related to birth asphyxia. Therefore, Helping Babies Breathe really focuses on bringing interventions to resource-limited areas that are cost-conscious and effective. The program is taught primarily to those with at least basic skills necessary for delivery. The program also focuses on what's called the golden minute. This is the first minute of a neonate's life where interventions that are simple can be life-saving. Among the 10 to 20% of babies who do not breathe at birth, many will respond to drying and warmth, clearing the airway, and stimulation to breathe. For 99% of babies, these simple interventions can be life-saving. Unfortunately, without these critical interventions, within the first minute of life, the neonate's heart rate and blood pressure will continue to lower, causing death. Only a small percentage of newborns, about 3 to 6%, will actually require bag mask ventilation, and less than 1% of neonates require advanced methods of resuscitation, such as chest compressions, intubations, and medications. In 2013, a study out of Tanzania utilized the Helping Babies Breathe program. They found that there was a 47% reduction in neonatal mortality within 24 hours. They also had a 24% reduction in fresh stillbirths. Some additional important findings were that with the focus on that first minute of life, the golden minute, there was a significant increase in stimulation and suction with the training, and there was also a decreased need for BVMs. So when we take a look at Haiti, where we decided to use the adapted Helping Babies Breathe program, we thought that we would use the core measures and techniques of Helping Babies Breathe because Haiti also had a very high neonatal mortality rate, 27 per 1,000. It's a country with limited resources and personnel, and it's thought that about 25% of neonatal deaths are related to birth asphyxia and birth trauma. So we partnered with Haiti Community Health Initiative, which is a nonprofit organization that was started in 2012. It employs community health workers and works primarily in the villages near RKA. They have several medical and surgical clinics annually, And they also include projects on sanitation, clean water, and recycling. The community health workers are really at the heart of this program. They are selected by the villages that they work in. They're given 6 months of basic health education and training on teaching health education. They visit each house in their village on a monthly basis to assess individual health, follow up on people with chronic diseases, give health education about nutrition, hypertension, and safe pregnancy. In Haiti, about 49% of women who deliver have a skilled birth attendant. We found that in the villages that we were working in, only 14% of women delivered in a hospital, and most of them did not have a skilled birth attendant. So we realized that our rural population had even an increased challenge of access to trained birth attendants and access to healthcare facilities. So this is why we created the Adapted Helping Babies Breathe program that could be used for lay people. To start the program, Helping Baby Breathe trainers were brought down to teach the community health workers the program with the focus on the fundamental skills of neonatal resuscitation and the golden minute. From this program, the community health workers were then able to teach lay people who were chosen by pregnant women to be their birth attendant. All pregnant women were given a birthing kit, regardless of their participation in the program. The big difference of the Adapted Helping Babies Breathe program from the traditional is that in this setting, the women were not giving birth in a healthcare facility, and it was lay people that were as the birth attendant. Thus, we decided to remove the BVM because it can be a very difficult skill to master and has possible complications. From the Tanzania study, we were also encouraged that with the focus on the first minute of life, there was a decrease in the need for the BVM, and there was an increase in just simple techniques that could be life-saving, such as stimulation, drying, and warming. The birthing kits that were given to the women included soap, gloves, blankets, razors, string, and bulb suction. So our study, the primary outcome was newborn mortality, with secondary outcomes in maternal mortality, composite outcomes of ill health and mortality for both the mother and the newborn. It was a retrospective cohort study of lay neonatal resuscitation program. It was done in RKA, Haiti from July 2015 to May 2019. The data was collected by the community health workers, and the study was approved by the University of Iowa Institutional Review Board. The women were chosen after they were pregnant by at least 20 weeks by their last menstrual period. They could have been chosen and recruited from the clinics that go on annually or when the community health workers were visiting their communities. Verbal consent was obtained. And again, pregnant women were the ones who chose their birth attendants that the community health workers then trained in an Adapted Helping Babies Breathe program. The birth attendant was offered 3 separate trainings, and this training required testing on mannequins to make sure that skill retention was present. So our intervention and controls were, the intervention was that there was a birth attendant trained in the Helping Babies Breathe adapted program present at the time of birth versus the control with no birth attendant with Adapted Helping Babies Breathe training present at the time of birth. So our study population was initially 780. However, we did lose data and had to exclude it from the overall analysis of the population due to no neonatal health status or missing Adapted Helping Baby Breathing training status on there. And that was about a 30% loss of data. So our intervention group was 452 and our control was 84. Follow-up was obtained by the community health workers who sought out the mothers after delivery to check on health of baby and mom, and then also whether there was a birth attendant trained that was present at time of birth, if the supplies were ready, to get any feedback on the program, and then they then added data into the de-identified database. So for our results, the primary outcome, there was no statistically significant difference in neonatal mortality. However, in our secondary outcome, we did see a decreased odds of the composite outcome of newborn mortality and ill health. Maternal mortality was too low in either group to give us a good analysis. So what this shows us is that the Adapted Helping Babies Breathing program shows promising results that community training with lay persons in low resource settings may reduce neonatal ill health, which included ill or dead neonates. We think this is helpful because with neonatal mortality and the great discrepancies across the globe, we do need to continue to find innovative ways to reduce global neonatal mortality. One of the limitations of our study was that it was not powered to find a difference in neonatal mortality. There were an overall low number of neonatal and maternal deaths. We did lose about 30% of data due to missing exposure and outcome status. So moving forward with the goal of reducing global neonatal mortality and ill health, when you have resources present and have birth attendants that you have access to, the Helping Babies Breathe program has been shown to have great success. However, there are many places still that are unable to get access to a trained birth attendant. In those situations, you can consider using an adapted Helping Babies Breathe program to be used. We do recommend annual retraining of all the educators and that the lay persons who are the birth attendants, that they train at least 3 sessions. Other recommendations include a further study that was powered to find a difference in mortality, and also a qualitative follow-up study. We don't have data on why the neonates died and what was the timing in relation to birth, whether it was within the first 24 hours or within that first month of life. We did continue to share this information with all the communities involved in the program, and we recommend that all programs moving forward also share the information with the populations they're working with. I just want to give a thank you to all of the people involved, the communities of RKA, the community health workers that really were at the heart of this program, the Community Health Initiative in Haiti, and then all of my colleagues at the University of Iowa who partnered in this program. Thank you very much for your time today.
Thank you, Shannon. That was wonderful. Our next speaker will be Karina Weinstein. Karina leads the FXB Climate Advocates Program and the FXB Climate Emergency Village. Previously, she provided capacity building services to junior leagues to strengthen their community impact programs. From 2008 to 2012, she lived in Mexico and held leadership positions in diverse social change organizations dedicated to alleviating poverty. Please join me in welcoming Karina Weinstein.
Thank you so much. It is such a privilege to be here today and have an opportunity to share with you about the FXBVillage model. So just really briefly, I want to tell you about FXB International. We were founded in 1989 by Albina Dubrauer-Ray in memory of her son, Francois Xavier Banud, who died in a helicopter crash at the age of 24. Since founding, we have always been focused on children and improving the lives of children by strengthening the capacities of families and caregivers to provide for them. FXB has 3 areas of action: practice, policy, and advocacy. So when we started in 1989, there was a common program intervention of microcredit to help communities overcome poverty. FXB broke away from the trend of microcredit. Instead, FXB provides in-kind seed capital for families, participating families, to launch income-generating businesses, augmented by mentoring and mentoring, business training, financial literacy, and savings groups. In this way, our participating families are not indebted to financial providers, but instead can generate income and become self-sufficient. And today, we're working on adapting the FXBVillage program to strengthen the resilience of our families to tackle climate change and disruptions caused by climate change. And so we're looking at how we can promote climate adaptation and restoration activities, both on the individual level as well as within the community. So we work in 11 countries, and we have offices in France, Switzerland, and the United States. As I said, our FXB is really focused on children. So FXB was founded to realize the Convention on the Rights of the Child. Also, what guides our work, and specifically the FXBVillage model, is the inextricable link between health and human rights. So we know that we cannot address challenges in silos. You know, if a child goes to school but is hungry, the child cannot learn. Or if a family has access to medical care or medicine but goes home to unsanitary living conditions, then they will still face challenges. So really our program is based on this idea that we must address multidimensional poverty through an integrated approach. So because our program is integrated and holistic, the FXBVillage model, we tackle multiple sustainable development goals, and really the SDGs are the framework that guide our work. We currently have 52 programs in 13 countries. 10 of those programs are FXBVillage programs. So what is the FXBVillage program? It is a 3-year program that provides integrated support to a cohort of 80 to 100 families in a community. And as I mentioned, we're constantly thinking about how we can strengthen the resilience of our families and integrate climate change adaptation and mitigation, because we know globally that 100 million people are threatened to be driven back into poverty because of climate change by 2030. And 2 specific strategies that we're implementing and researching further include promoting behavior change at individual and community level, as well as encouraging climate restorative income generating activities. So we currently have 10 FXBVillage programs in Burundi, Myanmar, Mongolia, Namibia, and Rwanda, with a total of over 200 that we have implemented since 1989. So now I want to walk you through the different program components of the FXBVillage model. As I mentioned, this is an integrated program that provides support across multiple drivers of poverty in a simultaneous fashion during the 3 years of the program. So the first component is economic empowerment. And what this means is that FXB provides startup capital to participating families to launch small businesses, as well as access to financial savings, financial literacy, business training, and vocational skill training when necessary. And once families start generating income and want to grow their businesses, we help families connect to microcredit. Nutrition is really important. We find families that have children that are malnourished. And so the first year of the program, we provide food distribution supplements to the families, as well as we teach families how to start a kitchen garden that then enables them to have some basic access to some basic vegetables and herbs and things they can use, food they can use for their consumption, and to have a quality diet. So health, we look at health as both mental and physical health. So with health, FXB facilitates access to existing health clinics, so to existing health infrastructure, whether local insurance schemes, as well as access to clinics, as well as psychosocial counseling and support, and hygiene practices are also promoted. In terms of water, sanitation, and hygiene, FXB facilitates access to drinkable water and basic sanitation services such as latrines, ventilated kitchens, external showers, and hand washing stations. Education is very important. So FXB provides financial support for families with school-age children to pay for school supplies, school fees, uniforms, to make sure that children are enrolled and are attending school, and that youth that are out of school have access to vocational skill training. And so all the 5 components I just described help the 80 to 100 families in our program. But we know that families live in communities, and for a lot of the behavior changes that we want families to adopt, it's actually really important to engage the whole community. So FXB provides community-wide training on topics such as family planning, hygiene, and children's and women's rights. So in addition to being an integrated and holistic program that addresses multidimensional poverty, the FXBVillage model is also a graduation program. That means our families graduate out of the program after 3 years. And we also gradually diminish our financial support to the families throughout those 3 years. So in the first year, FXB covers 100% of the health and educational expenses that I described. In the second year, participants start covering 25% of those expenses, and in the third year, 50% of those expenses. And really what this enables is for participants to become active stakeholders, really kind of engage in their own improvement of their lives, regaining dignity, the fact that they're improving because of their effort and not because of external aid provided by FXB. And really FXB is kind of the guide and the support throughout those 3 years for the families to achieve their goals of improving their house, of starting a small business, of making sure that their children attend and complete school, etc. And as I mentioned, we're currently realizing that the gains that the families make in our program are vulnerable or at risk due to disruptions caused by climate change. And so we've started to think about how we can help our families prepare for some of these natural disasters or disruptions, as well as build their resilience. So specifically in Burundi, we have started to implement training on disaster risk and mitigation, training of our FXBVillage participants on more productive and sustainable agricultural systems, creating farmer field schools where they can learn ecological practices and adaptation to climate change. Something as simple as broadcasting messages via text messages and phones about weather forecasts so families know when there's a heavy rain coming, disaster warnings, and wash-related messages. And as I mentioned, some of those individual and community behavior changes, such as improving recycling practices and making sure the communities have the infrastructure to be able to recycle. So what's interesting is that FXB villages have been implemented in Asia, Africa, and Latin America, and we have a comprehensive monitoring and evaluation system where we measure across all of our program components, indicators at baseline and at endline, and across the different geographies, we get consistent results, and I'll just mention some of those that are on the slide. 85% of participating families attain economic self-sufficiency after 3 years. 80% of our families contribute regularly to saving at the end of the program. 93% of the families are eating at least 2 nutritious meals a day. And so what's powerful about a program like the FXBVillage model is that while it is nimble in its design and can be easily adapted to the specific needs of the community, you know, an income generating activity in China will differ than an income generating activity in urban Rwanda, for example. But the core of the program being integrated, so tackling multiple drivers of poverty at the same time, as well as having a finite time period, so a graduation program where families know that within 3 years they are going to become self-sufficient. Those two factors really make the program successful across different geographies, regardless of how the program is adapted to the needs of the specific community. And when funding allows us, we try to measure the impact and if the families have sustained the improvements over the years. And in a large study down in Uganda and Rwanda, we know that even 4 years after the program ends, 86% of the participating families continue to live above the poverty line. And just everyone always asks us about the cost of the program. So the cost is $125 to $150 per participant per year. So we think it's a very wise investment into helping families gain self-sufficiency. And we encourage you to download the FXBVillage Model Toolkit and Planning Guide. This is a really great comprehensive resource that has the framework that goes behind this integrated program, as well as really concrete tools and templates you can use to either implement an FXBVillage program or integrate your existing program that maybe for now just addresses one aspect, health or education. But by using this toolkit, you can think through how to integrate and augment the work you're already doing. Thank you very much.
Thank you so much, Karina. That was really, really interesting. Our next speaker is Jack Wong. Jack is a clinical associate professor of pediatrics at the University of Vermont Larner School of Medicine. He has been involved in healthcare efforts in Haiti for over 35 years, most recently working with Health Equity International at the St. Boniface Hospital in Fond-de-Blanc. Please join me in welcoming Jack Long.
Thank you very much. Health Equity International is the parent organization of the St. Boniface Hospital, which is located in rural Haiti. I'm going to present a challenge we are currently facing at St. Boniface in hopes of generating some thoughts about potential solutions. But first, I want to give a little background on Haiti and on the hospital. Haiti is a country of between 11 and 12 million people, about the size of the state of Maryland. It occupies the western half of the island of Hispaniola. By most economic, social, and health measures, it is the poorest country in the Western Hemisphere. The St. Boniface Hospital, indicated here by the green star, is located about midway in the southern peninsula. Haiti has a centuries-long history of political and social turmoil, and events over the past couple of years have only magnified these problems. Earlier in the month of March, the U.S. Congress Human Rights Commission said that Haiti is caught in a perfect storm of failed governance, corruption, poverty, lawlessness, and insecurity. In January, the country slid into rule by decree under the current president. The St. Boniface Hospital represents a small oasis of stability in this turmoil. It is administered and fully staffed by Haitians and is an example of what can be achieved in spite of the conditions in the country. St. Boniface began as a single-room clinic in the 1980s, but has grown to a 130-bed tertiary hospital, offering essentially free care to a region that encompasses 2.3 million people. The services include inpatient, medical, surgical, pediatric, obstetrical wards. There's a 24-bed neonatal intensive care unit. There's a round-the-clock emergency room, as well as an infectious disease unit with isolation rooms. In the midst of deteriorating social conditions, as the state-run facilities have been chronically underfunded, understaffed, undersupplied, and usually underutilized, St. Boniface Hospital has become overburdened by patient demand. And I want to give you a few examples. This is a graph of the annual outpatient visits seen at the hospital over the past 5 years. In 2015, there were about 52,000 outpatient visits. In 2019, that number had grown to over 110,000. This is a similar graph of deliveries of newborns over that same time frame, 2015 to 2019. In 2015, there were about 1,300 deliveries. Last year, there were almost 4,500 deliveries. And this depicts the number of NICU, neonatal intensive care unit admissions over that time frame. In 2015, we had 338 NICU admissions. Last year, over 1,200. Well, how has the organization managed to keep up with this demand? It's always been a very lean organization, but they've had to become even more efficient, doing things, for instance, like streamlining their supply chain. And they've continued to be successful in their fundraising. This is a graph of total operating revenues over the past 5 years, and looked at it in isolation, it's fairly enviable. But if you look at it in comparison to patient demand, you see a different story. On the far right, the bar represents the operating revenues. They've increased 80% over the past 5 years, but they're dwarfed by the increases in outpatient visits, deliveries, NICU admissions, and other services that are being provided by the hospital. So qualitatively, this is the same dilemma which is faced by the government health centers, which are grossly inadequately staffed and supplied. The quality of care is going to be put at risk by these supply side constraints. What are the potential risks of this increase in demand? Well, the most obvious is just crowding in the clinic. This leads to patient and provider stress and the risk of contagion of infectious diseases. The providers have less time to spend with each patient, and this can result in misdiagnoses and mismanagement of their illnesses. Increased patient burden will lead to faster depletion of resources such as gowns, gloves, masks, essential medications, surgical supplies, And all this can lead to suboptimal patient care. And the longer hours and the increased pressure on the staff can lead to burnout. The physical and emotional exhaustion that they're going to experience can lead to an increased risk of medical errors. But the biggest fear is that these inadequate resources may eventually lead to an increase in morbidity and mortality. It's something that we're tracking. We've not seen this yet, but it's a looming fear. Well, how can we respond to this increase in demand on services? Well, the default mode is to keep calm and carry on. This is the easiest route to take, and it's the route to which the providers on the ground are most likely to take absent any other direction. It goes without saying that we're always trying to increase our funding base, but this takes, as you know, it takes time, it takes staff, it takes money to raise money, and it's very difficult to find unrestricted funding to help support your ongoing operating costs. Grants are most often drive other agendas. We could search for other health centers to try to develop networks, health alliances, but with the current state of affairs in Haiti, it's just not realistic. There really aren't any adequately functioning health centers with which we can ally. We could start to limit the patient numbers. We could make that a hard stop, close the doors of the hospital at a certain time of day, or develop triage systems so we're only seeing the sickest or the poorest patients. But developing those triage systems takes staff, takes training, and it's very difficult to decide how to set those limits. We could consider limiting services. For instance, deciding that certain lab services just weren't worthwhile, or that we really should be focusing on non-communicable diseases, chronic diseases, rather than surgical services. But again, these take a lot of thought and a lot of planning. But whenever a service or commodity is scarce, valuable, and controllable, it raises the specter of rationing. In the medical field, we often avoid this word because it has such negative connotations. However, with the recent coronavirus crisis, it's certainly getting a lot more attention. It also raises issues of medical ethics, which are well beyond the scope of this talk. But if our goal is to supply equitable, cost-effective services while minimizing expenditures, rationing must be considered, but it should be explicit. If health ministries and non-governmental organizations do nothing, then hidden norms and rules will be applied, often by the frontline health providers, leading to a de facto rationing system which may not be consistent or fair. What we need is a transparent system based on clearly defined indicators, such as prevalence of the disease or the age, sex, or clinical status of the patient. Well, underlying any discussion of how, with limited resources, we make healthcare more accessible and equitable is the Sustainable Development Goal of Universal Health Coverage, or UHC. Now, two approaches to UHC were contrasted recently in the pages of the journal Lancet Global Health, and they might give us some guidance on how to proceed in the current environment. In a commentary titled A Practical Approach to UHC, the group from Partners in Health made a case to use what they call their UHC monitoring and planning tool to address perceived gaps in care. This tool gives users a way to assess the burden of a particular disease, determine the anticipated patient volume which will be seen if 100% of the disease is treated, and to estimate the need of the staff, material, and infrastructure. These forecasts can then be used to convince funders to provide needed resources. In response, a group from the Netherlands said, okay, but given the reality of limited funding resources in the short term, the real challenge is to set fair and sustainable priorities in what services to provide first under the progressive realization of universal health coverage. They advocated for using what they termed evidence-informed processes. The Partners in Health group countered, saying that their approach would generate the data needed to meet funding targets, and we must root all of our action in the universal right to health care rather than in an acceptance of inequities cloaked in the language of sustainability. Further, they said if we choose interventions that are considered sustainable, we'll preserve the unacceptable and inequitable status quo. Well, what guidance can we take away from these experts? Who is right? As is often the case, both approaches are valuable, but first we should acknowledge that when confronted with this dilemma of constrained resources, continual expansion of services may not be the way forward. Perhaps there are times when temporary realignment of needs with resources or even contraction of services may be necessary, at least in the short term. We can't leave it to providers who will, of course, always prioritize the patient sitting in front of them. We have to set guidelines at the organizational level. And we have to involve all the stakeholders at the national, regional, and community levels. And they all should understand that resources at any given time are finite. We should use evidence-based tools to identify and to rank priorities, and then use tools such as the Partners in Health tool to assess needs and convince funders that due diligence was done before asking for support. But we have to be bold. We can't resign ourselves in long-term planning to the constraints of the current budget envelope as we try to move towards progressive attainment of universal health coverage. We are entrusted to make the best use of available resources in the interests of the patients we serve. We should not be stymied by over-strict adherence to a single practical or philosophical approach. But we should accept that at times new strategies will be necessary to provide more with less. Thank you very much.
Thank you, Jack. That was a really thoughtful and thought-provoking presentation. Our next speaker is Lindsey Pollaczek. Lindsey is the Vice President of Programs at Fistula Foundation, an organization dedicated to ending the needless suffering caused by obstetric fistula, a devastating childbirth injury. She oversees the strategic direction of the foundation's program budget to enable holistic fistula treatment programs in 21 countries worldwide. She was also responsible for setting up and launching the local foundation programs in Kenya and in Zambia, where she was based for 4 years. Lindsey is a senior fellow with the Atlantic Fellowship for Health Equity, a program that supports global leaders working to combat health disparity and promote equity. Please join me in welcoming Lindsey Pollaczek.
Thank you, Amy, and good morning, everyone. It's a pleasure to be here virtually with you all today. I wanted to speak a little bit about the work of the Fistula Foundation, specifically the work that we've done in Kenya in partnership with the Ministry of Health and other stakeholders as we're working toward the elimination of obstetric fistula. So obstetric fistula is a childbirth injury. It's caused primarily by prolonged obstructed labor when a woman goes days, hours, days without prompt medical intervention, such as a cesarean section. The symptoms of fistula are continuous leakage of urine and or stool through the birth canal that happens after the prolonged obstructed labor creates a hole or an abnormal opening, as you can see in the diagram, due to the prolonged fetal pressure. Of course, we know the consequences and the symptoms physically are devastating, incontinence, but the psychological, the emotional toll, the economic consequences that this condition can have on the lives of women and their families is even more devastating. The prevalence of fistula is estimated to be more than 1 million women worldwide, primarily living in sub-Saharan Africa and South Asia. We know that fistula affects the most vulnerable women in society, those who are poor and are living in rural areas. In Kenya, as in many other places, the actual sort of incidence and prevalence of fistula is scarcely known, the data is not good. So we do tend to look at proxy indicators such as maternal mortality to give us a sense of the scope of the problem. In Kenya, we know that MMR is 362 per 100,000 live births, and we know in the rural areas, few women are delivering in the presence of a skilled birth attendant. The UNFPA did conduct a needs assessment, but many years ago, and at that time, they estimated 3,000 new cases each year. And the Kenya Demographic and Health Survey, which of course is a snapshot in time, in 2014 suggested 14,500 women experiencing symptoms. In Kenya, prior to 2014, there were approximately 1,000 surgeries that were done each year across the country. So in this context, Fistula Foundation, together with support from Astellas Pharma, EMEA, launched a program we called Action on Fistula. And the idea of Action on Fistula was to create an integrated treatment and outreach network that would enable more women to get timely and quality care, and also build the long-term capacity to handle fistula in Kenya. And we wanted to look at the key barriers that were limiting a woman's ability to access this care as we built our program. So the 5 program objectives, of which I will speak of about 3 today, given our limited time together. First was to establish this routine fistula treatment service at a network of hospitals strategically placed throughout the country. Second, to train fistula surgeons and healthcare providers involved in fistula care and management. Third, to create a community of practice for fistula surgeons and key stakeholders to elevate the visibility of fistula care in the country. Fourth, to strengthen community outreach to improve awareness, reduce stigma, and enhance referral of clients to appropriate treatment centers. And finally, to develop community reintegration programming for women following fistula repair to promote psychological well-being and economic empowerment. So I'll talk about 3 of the objectives today, the first being this treatment network. Before 2014, there were only 2 sites in the country that were delivering routine services. Most fistula care was delivered through what we think of as fistula camps, or sort of fixed time period service availability. So a surgeon from the capital or perhaps from abroad would travel in and visit some of these regional referral hospitals and deliver care for 1 to 2 weeks per year, or as funding allowed. And it was largely believed by the government and other stakeholders this was not the ideal way to deliver care, and there was a desire to integrate and institutionalize fistula care into the service availability at the hospital. So through the program, we were able to create a network and launch new programming, so that by now there are 7 hospitals in Kenya that are providing routine fistula surgery. Over 5,700 fistula surgeries were performed in the past 6 years. The average age at treatment was 36 years, and the average duration living with fistula was 8.5 years. We measure success of the surgery that the woman leaves the facility with her fistula closed and she is continent. So with that measurement, over 90% of women left the facility with a successful repair. And the network does support covering the cost of surgery, but also ensuring that the facility has the right supplies and the right equipment to deliver those surgeries. The next objective was to train fistula surgeons. We knew that this was a major bottleneck in delivering care in Kenya, as it is in many other countries, because fistula surgery is not part of the traditional training curriculum. So we partnered with the International Federation of Gynecology and Obstetrics, which has developed a competency-based fistula surgery training program. And we also invited them to come certify one of the hospitals in Kenya, where one of the expert surgeons and his team were based. So through FIGO, we did manage to accredit a fistula training center in Western Kenya. We trained 4 Kenyan expert surgeons to become trainers, and 11 new surgeons were trained over the period, including 7 Kenyan doctors and 4 doctors from the region, Uganda and Zambia. We've also been able to provide advanced workshops and seminars both in Kenya and outside of Kenya. And we've focused not only on the surgeon, but also providing this training to ward nurses and theater nurses. And since this is a community strategy group, I wanted to, of course, highlight the importance of the community outreach and mobilization to the work of the Kenya program. We know that low awareness and understanding about fistula in the community setting is a huge barrier, and many women lack transportation funds to get to and from the facility. So with that in mind, we formed partnerships with 5 Kenyan community-based organizations and NGOs to really focus on that grassroots mobilization. And this has really been the heart of the program work that we've done in Kenya. So through this program, we've trained over 370 community health volunteers. And these volunteers, of course, are the frontline health workers in their communities that are going around household to household, from market to market, sensitizing people about fistula signs and symptoms, how to prevent fistula, and how fistula can be treated, and where that treatment can be received. We've also done a lot of work of sensitizing health center staff. We recognize that many nurses, clinical officers, and midwives are not familiar with fistula. It's not part of their medical education, and therefore a lot of the diagnoses of fistula is missed at that level. We've spent a lot of time developing radio messaging and content that we've broadcast in vernacular languages across Kenya. And finally, we're utilizing sporting as a technique. So for example, we have a women's football team that plays in the Kenya Premier League that is called Let's Kick Fistula out of Africa, that plays a great football match, but also does a lot of work to sensitize the community. And as a result of these efforts, 85% of the surgeries we can attribute to the community engagement strategy. So what have we learned? We've learned it's difficult to find and retain surgeons who are interested in doing fistula surgery. Of course, fistula surgery is not something that pays very well, and finding people who are motivated to do this work, which is also can be very complex, takes a lot. We've also found that training is a process, not an event. It's not enough just to provide a 6-week training to the surgeon, but they need that ongoing mentorship and support. We found that women living with fistula who do often live in rural areas find it difficult to travel to a far place like the capital for services. So bringing care closer to where they live and work has been essential. The community mobilization and the community engagement takes a long time to build. It's a lot about building trust. And so working through grassroots organizations that have a long-term stake in the well-being of their communities has been very much essential, and adapting to the needs of the communities in the particular context. And finally, that women themselves who have had the lived experience of fistula are powerful ambassadors and should be part of the solution. We've created a fistula survivors movement in Kenya that's training hopefully over 100 fistula survivors this year to be advocates and ambassadors in their communities. Going forward, we have worked already with the Ministry of Health to create a training for community health volunteers so that all community volunteers across Kenya can be sensitized on fistula and start to do the work on the ground that will be essential to identify, refer, and eventually prevent fistula cases. We're also working to roll out the national strategy for the elimination of obstetric fistula in Kenya, together, of course, with the Ministry of Health and other stakeholders. The FIGO Training Center will continue to train more surgeons from Kenya, but will also be training surgeons from the region as a whole. And we're hoping to replicate this model of treatment, training, outreach, and rehabilitation in Zambia, which we have already done over the last 3 years, and in more countries in the future. And with that, I will end. Thank you very much.
Thank you, Lindsey. That was wonderful. We have a few minutes for a brief conversation among the panelists.
Well, I think that you know, the focus for my presentation, you know, really was sort of the overarching problems that all of us have probably faced at one time or another. You know, how to continue providing the programs and services in a climate where funding is becoming increasingly difficult, you know, to obtain. I'd be curious to hear from the other panelists how they have, I'm sure they face some of these problems, and I'd be curious to know if they have any novel solutions to it. I actually have a specific question for Shannon regarding the HBB program, and the question being, knowing that Haiti as I do, and having been involved in a lot of HBB programs, mostly in the Artibonite Valley, actually one of which was supported by the FXB Foundation. But the difficulty we saw was retention of the skills, and that we were focused primarily on, we did have community health workers, but also was focused primarily on the nurses who were in the birthing centers. At that time in the network, the Partners in Health Network, about 30% of deliveries were taking place, you know, in the hospital. We were focusing with nurses, on nurses, and found that the retention of their skills was actually quite poor. Not a reflection on them. I think it's just all of us see the deterioration in these skills. Any of us who have taken CPR courses know that you need to continue to practice. Have you, Shannon, been able to institute any kind of ongoing refresher courses for the community health workers in Arkai?
Yeah, thank you very much. You're right, and there's been some studies out of Tanzania as well that have shown that without continued, at least annual retraining, you do see that decrease in retention of skills. And so our community health workers, it's been about every 6 months to a year, they kind of get a refresher, the community health workers do, in the key elements of the program to kind of help retain that as well.
Great, that's good to hear, because I agree, that really is critical.
Yeah, and it's why we also recommend with the lay persons who are involved as the birth attendant to really try to get that 3 trainings in before delivery if possible, just to really solidify the key techniques to focus on the baby, which so oftentimes the initial focus was always on mom, and really that first minute of life, if you just focus on baby, you can make a big difference.
Absolutely, thank you.
Thank you.
Jack, this is Lindsey. I was really, I caught up in your dilemma that you were sort of articulating for us, and you kind of left us in a cliffhanger a little bit. And I'm wondering how you with your team have decided to move forward, or what you're thinking at this moment.
Well, it really is in flux right now, and the organization is struggling with it. No firm decisions have been made. I think that, you know, I alluded very briefly to the issue of rationing of care, and it's something that I think all of us find somewhat distasteful to talk about. But more and more, I'm becoming convinced that we have to face up to it, that we need to look at the broad picture of universal community health and try in our individual communities that we serve decide where we can get the biggest bang for the buck, and these are very difficult questions to answer. And as I mentioned, they raise these ethical issues. But we really have to grapple with, is it better for us to face actually contracting our services? And I would use, for example, surgery. We have a very busy surgical service. And surgery is something that is obviously very difficult for us to give up. But if we look at, should we be looking at things like, quality adjusted life years and things like that in our community, these, public health measures, and perhaps decide that we really would do better for our community if we focused on hypertension, if we focused on diabetes, if we focused on chronic diseases rather than acute problems. It's almost impossible for a hospital which has been operating for 30 years to suddenly change course and say, no, we're going to close our doors to this type of patient. You have to seek care elsewhere, knowing that in Haiti right now, there is no elsewhere. We really are the providers of last resort. But I think that if we don't grapple with these things and really try working with the ministries of health and the regional health representatives, if we don't make some decisions about these problems, we may sort of bankrupt ourselves and find that we're not doing anything very well. We struggle with getting good data about how we're doing. We have a good monitoring and evaluation team in the hospital, which gives us good data about outcomes in the hospital. But when you have an average length of stay of 4 hours for a woman who's postpartum, and then she goes back to the community, she's lost a follow-up. We really don't know much about the outcome for that particular woman and for that population. And so we don't have a good handle on how well are we doing. And it's really, we're stumbling around in a way in the dark, and we don't have an answer. Well, that's a long-winded response to say, no, we don't have an answer, and we're not exactly sure what we're going to be doing.
Thank you so much, Jack. We really appreciate all of the information that our speakers have provided today. You've given us a lot to think about, and quite honestly, a lot to be inspired by. I look forward to future conversations about these particular interventions and about the incredible work that you're doing. This session is now concluded.